Okay. Arne, आप बैठेंगे स्क्रीन शेयर करना ඉවර දාම එතකොට ඉවරයිනේ මම හිතන්නේ ආයෙත් පීඩියාට්‍රික් ඇන්ඩ් මෙඩිසින් MCQ වගේ ඊළඟ සතියේ කරන එක වැදගත් කියලා මොකද ඔයාලටත් ස්ටඩි කරන්න එපා ටයිම් එක නේද මේ මොකද කියන්නේ කට්ටිය මොන හරි ඕනද
නෑ බං මේ අරටික බක ගන්න නේව දැන් පොඩ්ඩක් මේ වෙලාවදී
ඔය ඒක තමයි ආයි වතාවක් MCQ මම කරන්න ඕනේ දැන් කරලා තියෙන ටිකක් ඇති ඒ ටික බලන්න හොඳයි ඔව් right මේකෙන් ඉවර කරලා දාමු එතකොට අදින් පස්සේ MCQ discussions නෑ right ඒකේ shape නේද අලේ මට ඕන එකක් මට next week උත් අවුලක් නෑ අලේට පොඩ්ඩක් කෝල් එකක් ගන්න පුළුවන් නම් දේශබන්දු ඒක පොඩ්ඩක් අහලා මට කියනවද පස්සේ දේශබන්දු මචං ඔබට පුළුවන්
අහලා ඔව්
right okay
hello
okay ඊළඟට යනවා 26 එක 70-year-old previously healthy patient undergoes TURP under spinal anesthesia. The surgery lasted for 90 minutes. 30 minutes after completion of the surgery, the patient becomes restless and confused. What is the most likely cause for this confusion? What do you think is the most likely cause for this confusion? It is most likely due to low sodium levels. This is called post-TURP syndrome, right? This patient being confused and restless is called something called post-TURP syndrome, where the patient gets when you cut the prostate in TURP, you use a laser and you cut the prostate. So all the water or the saline or the normal saline or 0.9% sodium chloride that is used to wash the prostate gets absorbed through the prostate parenchyma. Okay, so when it gets absorbed through the prostate parenchyma, right, when it gets absorbed through the prostate parenchyma, what will happen is that they will get hypoosmolar hyponatremic fluid overload. Okay, so that is what we call as TURP, hypoosmolar hypoosmolar hyponatremic fluid overload, and that actually leads to complications like what do you call this, acute hyponatremia. That leads to complications like acute hyponatremia, and that can also cause complications like acute heart failure, and that can also cause complications like acute pulmonary edema, right? And they can also get something like hemolysis also when they have hyposmolar hyponatremic fluid overload. Okay, so these are the constellation of complications they can get, and the most significant complication that will lead to them getting confused and restless is actually having low sodium levels, right? That is what usually causes the restless and confused state of the patient. Okay, so we go to 27th question. A 50-year-old man with a smoking history presents with hemoptysis and weight loss. A chest X-ray shows a 3 centimeter spiculated mass in the right upper lobe. What is the most likely diagnosis? So if it is a spiculated mass in the upper lobe, and if the patient has had hemoptysis and weight loss, the most likely diagnosis is a bronchogenic carcinoma. The reason is usually spiculated mass in the right upper lobe. It can be interstitial fibrosis also, but in interstitial fibrosis you won't get hemoptysis. Okay, and if you talk about secondary lung deposits, that can also cause interstitial lung disease. That can also cause hemoptysis, but usually you will see more deposits, not only single deposit commonly, right? You will see multiple deposits. So it is not ideally a secondary lung deposit. It cannot be TB also, because TB usually cause cavitation, the most likely diagnosis given the smoking history is a bronchogenic carcinoma. And next we go for this one, 28. A 25 or 45-year-old man presents with features suggestive of perforated peptic ulcer. A supine abdominal X-ray was done, but findings suggest the diagnosis. So if there is perforation, there should be free air in the bowel. However, you cannot notice any subdiaphragmatic free air in abdominal X-ray. You have to take a chest X-ray. So what you can identify is actually you can identify what you call as Rickler's sign, right? Rickler's sign kya the bowel wall, right? The bowel wall, the external and internal wall becomes transparent, or in the other words, the external and internal bowel walls, they become very prominent. Internal bowel walls, they become visible if when there is abdominal free air, right? So that is what is called Rickler's sign. And usually what happens is there is increased visualization of the falciform ligament. There is no impaired neme. This has to be increased visualization of the falciform ligament if there is abdominal free air, right? And then presence of multiple air fluid levels in the bowel is a feature of intestinal obstruction. Subdiaphragmatic free air in abdominal X-ray subdiaphragmatic free air is usually seen in the chest X-ray, right? It is not usually seen in the abdominal X-ray. It is usually seen in the chest X-ray. So this is the C is the correct answer, right? Valvular cunning index you will anyway see in all the patients with bowel with very high resolution X-rays of the abdomen. Okay, so we go to the 29th question. A 53-year-old male underwent resection for a large ischemic small bowel segment and reconstruction. What is the best nutritional management option in the initial post-operative period? So when there is a very large small bowel removal, very large segment remove karata passe, right? So the small bowel, is the one that increases fluid absorption, and the small bowel is also the one that actually causes, a majority of the nutrient absorption from the gut as well, right? So when there is a large portion of the small bowel removed, that can actually cause imbalance in the gut absorption of nutrients, and that will actually cause what we call as diarrhea, right? And that will cause chronic nutrient-rich diarrhea. So to prevent this, we need to give the patient elemental diet. What is elemental is we give the patient not complex carbohydrates, but we give the patient glucose or oligosaccharides, right? And we give the patient not what you call this lipids. You give the patient oligo and what do you call this oligo and you give the patient fatty acids, right? Fatty acids and mono and diglycerols, right? So you give the patient already half digested food in the elemental diet. So that is the treatment for this condition which the patients get when when a large portion of their small bowel is removed. And the condition these patients get when large portions of the small bowel is removed is actually called what do you call this? You call it short bowel syndrome. Okay, you call this condition short bowel syndrome. Okay, so just read around short bowel syndrome and the treatment of that. And then a 50-year-old male presents with persistent enterocutaneous fistula for last 5 weeks following an open appendicectomy, right? Last 5 weeks the enterocutaneous fistula open appendicectomy. BMI is 22. What is the next most appropriate step in management? So enterocutaneous fistula open appendicectomy. So for the fistula to heal, you need to defunction it, right? Defunctioning is the most important step in healing of a fistula. So the next step in management is to do a defunctioning ileostomy. Okay. And then because there are fistula there are certain features which aid healing in a fistula, right? There are certain features which aid healing in a fistula. So what are the things that aid healing in a fistula? If the blood supply is adequate, it will heal well, right? if there is absence of any infection, right? If the blood supply is adequate, it will heal well, and if there is absence of infection, it will also heal well, right? So absence of infection, blood supply adequate, and then also the aid in healing a fistula. What will be the aid in healing a fistula? Blood supply is adequate, absence of infections, and then also when there is yeah, these are the main ones that actually help in healing of a fistula, right? And then a 40-year-old female with a 1 centimeter uncomplicated sebaceous cyst on the face. What is the best management option? So you can actually, because this relatively 1 centimeter can chutta loku, so it's uncomplicated also. So depending on the patient, you can actually reassure. However, if the patient finds it abnormal, you can excise also. But the problem is after excision, you might have small scar on that area. So I think personally, reassurance is the best thing to do. Antibiotics are needed if it is infected, true, but it doesn't say it is infected because it is uncomplicated. So no need to give prophylactic oral antibiotics, and no need to give incision and drainage, because that will result in recurrence of the sebaceous cyst. So ideally the treatment is excision and removal of the the treatment is excision and removal of the sebaceous cyst. However, when you cannot excise and remove completely, you then give the patient the option of keeping it, and then when complications come, you can remove it, right? So next one, a 65-year-old woman after total thyroidectomy complains of mild to moderate anterior neck pain. No chronic pain, no opioid use. First line drug for pain management is the first line drug for pain management. Now patient can chronic mild to moderate anterior neck pain. Mild to moderate now, you don't need to give any opioids, because this patient is not having any chronic pain. So don't give opioids. You can just first line killer nyan. So there's a WHO pain ladder. That is what they have been asking in the underlying theory for this question. So if you can remember, the WHO pain ladder starts with non-opioid drugs first. So in non-opioid drugs, you start with something like paracetamol, and then you go with something like weak opioids like tramadol, right? And then you go for something like a strong opioid like morphine, right? And then ultimately you can go for something like even like fentanyl and regional blocks and etc, right? Regional blocks and so on. So each step there is usually in the first step you have paracetamol and NSAIDs. So each step you can add adjuvants. So what are the adjuvants that you usually add? You can add steroids, you can add different other complementary medications, acupuncture and other physical therapies are also used, right? So this is the WHO pain ladder, very rough version. So just go over the proper WHO pain ladder. There is a modified version now because that is important. Okay, WHO pain ladder surgery. So first one is non-opioid drugs and NSAIDs, and then weak opioids, then strong opioids, and methadone and etc. And then you go for epidurals and regional blocks. Yeah, so that is the usual pathway that you take in the WHO pain ladder. Okay. So next one. However, if this is very severe pain, now this is mild to moderate pain now. If this was very severe pain, you can start with a strong opioid like morphine and then gradually titrate it down. Okay. So next one, 33. A 55-year-old male received subcutaneous morphine following surgery. His respiratory rate is 8 and saturation is 89. So what is the most likely cause? The most likely cause is respiratory depression, right? However, in the subcutaneous morphine form, usually respiratory depression is not a common incidence. That I think Sanjeev has emphasized over and over again. They will have shallow breathing and reduced respiratory rate when they get opioid toxicity. So shallow breathing and what do you call this? They will get shallow breathing and reduced respiratory rate. And what you call this? Apart from this, you can also get pinpoint pupils in opioid toxicity. Okay, so this is a phenomenon of opioid poisoning, and the treatment for this is IV naltrexone or naloxone, right? The next one, a patient presents with traumatic head injury and extradural hemorrhage is suspected. Which drug has the best influence on the outcome of the patient? So extradural hemorrhage is usually due to middle meningeal artery rupture, right? Middle meningeal artery rupture. And the next one they're asking is what drug has the best influence on the outcome of the patient? So in the outcome of the patient, the best drug you can give is tranexamic acid, because you want to prevent the formation of the blood clot and causing pressure symptoms. So fentanyl will reduce pain. Sodium valproate might reduce the risk of fits. However, if the patient does not have any fits, no need of giving sodium valproate. Midazolam also no need to give midazolam. Fibrinogen concentrate we might give if the patient's PTINR is deranged. However, tranexamic acid 1 gram stat and then 1 gram per hour IV bolus might reduce the further worsening of formation of a blood clot, right? And the next one is 80-year-old boy, supracondylar fracture, distal pulse is absent. So supracondylar fractures is the commonest type of fracture, commonest type of upper limb fracture. Supracondylar fracture, commonest type of upper limb fractures in children, right? In children, supracondylar fracture is the commonest type of upper limb fracture. And they mentioned that there is distal pulse absence, so the vasculature is gone. There is a vascular injury. Saturation is, however, good with good waveform in the pulse oximetry, but it's the most appropriate management. So ideally, because this patient has a vascular injury, right? We don't know whether the artery is kinked, whether the artery is structured, and what is there in the artery. So ideally, we can do this first, closed reduction and assess radial pulse. If the radial pulse is still not present, then we will have to go for brachial artery repair, open reduction and internal fixation or internal stabilization is the treatment. Then of course, however, for now, this moment, we can try closed reduction and then reassess the radial pulse, right? Okay, so next one, a 2-week-old baby presents with persistent yellowish umbilical discharge. The umbilical stump has fallen off and there is no swelling. So the umbilical stump has fallen off, there is no swelling or redness. The baby is afebrile and well. What is the most likely diagnosis? So the patient has yellowish umbilical discharge. So if this is a yellowish umbilical discharge, this could be a patent urachus. That is the first thing that can be in this kind of patient. Yellowish umbilical discharge redness umbilical granuloma because there is no redness, this cannot be. The problem here is yellowish umbilical discharge the patient is not febrile and not having any features of infection. So emphalitis is infection of the umbilical stump, that also cannot be, and we know umbilical hernias don't present like this. So out of these, Meckel's diverticulum and patent urachus, usually Meckel's diverticulum is not open to outside, so the only answer that can be there is patent urachus. So you have to go through the structures in the umbilicus, the embryological structures in the umbilicus, and what each structure provides in the adult, and then in the fetus as well. So embryological structures in the umbilical cord, and then what they form when the umbilical cord becomes damaged and diseased, and they go into adulthood. What is the remainder of that umbilical cord which was already present is what we need to know. Okay, so the 37th one, a 2-year-old boy with intermittent cramping abdominal pain, vomiting for 2 days, lethargy, dark sticky stools, a palpable right-sided mass, and hyperactive bowel sounds. What is the most probable diagnosis? So these patients, usually 2 to 4-year-old patients, if they come with intermittent cramping abdominal pain, this also might say that the patient has patient actually lifts his legs up when crying, lifts the legs up when crying, and and also the patient has features of intestinal obstruction. There's vomiting, there's lethargy, and there's dark sticky stools. What we call these dark sticky stools is usually what we use the term red currant jelly stools, right? And this patient has red currant jelly stools, and there is a palpable right-sided mass. So usually, remember, in children with intersusception, right-sided intersusception is the commonest. So they usually get a sausage-shaped mass in the right side of the abdomen, in the right upper quadrant of the abdomen, right? The most likely diagnosis in this patient is most likely intersusception, right? Nothing else. Okay, so we go to the next one. The 60-year-old woman with 3 centimeters non-healing venous ulcer for 5 months in the gaiters area. So this is an indication for whenever there is a venous ulcer, right? This is an indication for varicose vein surgery, right? When there is a venous ulcer, this is an indication of varicose vein surgery. So when you talk about varicose vein surgeries, there are only a few indications for varicose vein surgery. One indication for varicose vein surgery is cosmetic reasons, right? When there is a cosmetic disfigurements, you need to do varicose vein surgery. And the other reason for varicose vein surgery is when there is a varicose venous ulcer in the lower limb, right? And then another indication for varicose vein surgery is when there is skin disfigurement. So if there is what you call this lipodermatosclerosis, venous eczema, and there is thickening of skin, you need to do urgent repair or urgent treatment of varicose veins. And then there is, they mentioned there is saphenofemoral incompetence. You know, there is 2 types of saphenofemoral incompetence, and then there is saphenopopliteal incompetence, and then there is also blowouts in the perforators, right? What is the most appropriate management? So what you need to do here is actually do saphenofemoral ligation and 3-layer compression bandage. 3-layer compression bandage, a venous ulcer, remember, having a venous ulcer is not a contraindication for 3-layer compression bandage, right? And this patient has had the ulcer for about only 5 months, so you don't need to really exclude malignancy because this is a short duration. So the treatment here is saphenofemoral ligation, and then if there are other perforating incompetence, you need to tie out the perforators. You have to do what you call this tap avulsion, or you can tie off the perforators, or do radio frequency ablation, microwave ablation, or even injection of a sclerosing agent. And then ultimately you have to apply 3-layer compression resins to heal the ulcer and the bulging varicose veins. Okay, and then 39. A transplanted kidney becomes dusty and congested soon after revascularization, despite good anastomosis. What is the most likely cause, they're asking? So this patient has had good anastomosis, however, soon after anastomosis, it has become bad. So the reason for this is actually hyperacute rejection. So there is a duration for each rejection type. So there are 4 main types of rejection. You know, one is hyperacute rejection, and then there is also acute rejection, and then there is also chronic rejection. So you need to know what are the time durations for each. So hyperacute rejection is from seconds to minutes, acute rejection is from minute to hours, and then chronic rejection is from weeks to months, right? These are the types of rejection times you need to know. Okay, and then the next one, new laboratory test for prostate cancer screening has sensitivity of 90%, specificity of 95%. What is the false negative rate? False negative rate means that, you know, sensitivity is actually the ability to detect true positives, right? So ability to detect true positives is actually sensitivity, and then specificity is ability to detect now if you take a population, right, we'll just draw the 2x2 table, that's easy. When you take a population, you have 2 main groups, right? You have in the population you have the group with the test being positive and the test being negative, And in the population, you have patients who are actually positive and who are actually negative. Okay. Okay, so we'll say right? These are the values here. So this is A plus B, and this is C plus D, and this is B plus D, and then this is A plus C. So now if you talk about the true positive patients, now test is positive for all A plus C. A plus C is the test positive number, but however in the population the truly positive number is A. So out of the test positives, the number of true positives is actually sensitivity. Okay. And then when you talk about the specificity is the ability to detect true negatives, right? So population එක negative කට්ටියකින් test එකේ negative කට්ටිය කොච්චරද? ඒ කියන්නේ B plus D එකෙන් D කොච්චරද කියන එක තමයි specificity කියන්නේ, right? The ability to detect true negatives and the ability to detect true positives is sensitivity, and the ability to detect true negatives is specificity. හරිද? So what they are asking is false negative rate. So what is the false negatives? The false negatives are population එක negative වෙලා ඉන්න කට්ටිය හැබැයි test එකේදී negative වෙච්ච නොවුන කට්ටිය. So that is C. Wait, just I got something wrong here. False negative false negative means the number of patients who are falsely negative. So they are actually true in the population, however due to test they are false. So this is B plus B out of the test negatives, right? So if you take these two, false negative rate is the 1 divided by specificity. So the answer to this is actually 5%, right? 5% තමයි උත්තරේ වෙන්න ඕනේ. හරිද? 1 minus specificity. හරි නේද?
හරි.
Any questions you guys have? මේ වල time durations බලා ගන්න හරියට in this one.
Okay.
And then we already mentioned about management of varicose veins, and then this one you know the management in intussusception. What you do is you do something called hydrostatic reduction first, and then after hydrostatic reduction you do something called pneumatic reduction, and then after pneumatic reduction also fails, you do open surgery, right? Open surgery. Usually you try both together at the same time. If one fails, you try the other, and then if both fail, you usually go for surgery. And then in this you need to know now. Just because there is vascular insufficiency, you directly don't do open repair. Open repair is indicated when there is continued absence of radial pulse. That is one indication to do open repair. And then the second indication is when there is no perfusion of the limb. However, in this patient, there is no radial pulse. However, there is perfusion of the limb is present. So when there is perfusion of the limb present with no radial pulse, we have to try with close reduction first and then recheck the radial pulse. If it is always again on there, then of course we need to open the patient. You guys already know about WHO pain letter and management of opioid poisoning. And then this one like this, you can get small MCQs which try to detect your common sense, right? So this is the face. So in the face there is high risk of scarring. So you have to balance out the weight of doing the surgery versus the rate of forming the scar. If the scar is still going to get formed, you can offer the patient reassurance. However, if the patient still wants the surgery, or if there is increased complications of the lesion, you have to provide the patient with the surgery, right? Then we discuss this. Okay, so that is it for the 2018 MCQ. Any questions? Surgery. finito. shape එහෙනම් group එකේ දාන්න මම හිතන්නේ ආයෙ වතාවක් MCQ කරන්න ඕන වෙයි කියලා.
MCQ ගමන මේ සර්ජරි වල අර මේ ඕතොපෙඩික් පාර්ට් එකට පොඩ්ඩක් බලමුද බං? ඕතොපෙඩික් අර පීඩ් කේස් එකට මේ
ඒකේ වා MCQ ටික කරලා මට එවන්නකෝ MCQ ආන්සර්ස් ටික මුලින්ම. right?
හරි.
වා MCQ හැබැයි මුලින් කරන්න ඕනේ. කරලා ඉවර වෙලා තමයි මට එවන්න ඕනේ. right? ඊට පස්සේ
SCQ පාර්ට් එක බං. අර SCQ ප්‍රශ්නයක් ඉන්නේ මං
SCQ ඩිස්කස් කරේ නැද්ද ඔයාලා? මේ පැත්තට.
ඒක බං මේ අර ටික නේ අපි කරේ එදා කරපු ටිකයි. ඊට පස්සේ ට්‍රෝමා කරා. ඊට පස්සේ බං මේ අර ඕතොපෙඩික් පාර්ට් එකයි මේ පීඩියාට්‍රික් සර්ජරි කරලයි වැස්කියුලර් කරේ නැහැ.
right.
just
ඒක තමයි නේ. මේ ඒ ටික මචං බලමු ෂුවර් නෑ. පුළුවන් නම් මම තරිෂිට කියන්නම් මේ ඒකම ඔයා කිව්වයි කියලා ඔයා වුණා තරිෂිට කියන්න මේ එයාලා අනිවාර්යයෙන්ම මේ ඒක කියයි. right?
මම කිව්වා බං.
එන අනිවාර්යයෙන්
මෙසේජ් එකක් දැම්මා. ඕකේ බං.
okay මචං. මේක
thank you very much මචං.
okay
thank you.
ඔක්කොම ටික හොඳට කරගන්න. මොන හරි ප්‍රශ්න තිබ්බොත් තව මොන හරි තිබ්බොත් කියන්න. හරි?
okay.
අලේටත් මැසේජ් එක පාස් කරන්න මචං.
thank you very much මචං.
alright. අලේටත් පාස් මැසේජ් එක පාස් කරන් තියෙන ඒ කියන්නේ ආයෙ වතාවක් මේ
okay.
ඩිස්කෂන් එක ගන්න. right මචං එහෙනම්. okay good luck.
හරි. thank you බං.